All right, well, my name is Matt Roosevelt. I'm one of the chief residents here at UCSF for internal medicine based out of San Francisco General Hospital. And I'm going to be talking about something that we call problem mapping, which is really just a model for case review. So the goals for this section are, I want to start out by talking about the importance of case review for learning and quality improvement in medicine. I want to discuss the challenges of performing an unbiased review, and then I want to spend a little bit of time appreciating how complicated and how dynamic real patient illness scripts are in real life, especially in complex cases. We'll then describe the problem mapping, and I'll show you how that works. And really this is focusing cases through a clinical problem-solving lens. And then finally, we'll see where we can use this problem mapping not only retrospectively, but potentially prospectively in clinical care and quality improvement. Okay, so to begin, let's talk about where case review plays a role in medicine. So I think consistent with what we've been talking about so far in this module, we use case review all the time to identify, evaluate, and remediate medical errors. I think the classic example of that is the root cause analysis. We also use that in morbidity and mortality conferences, so you see these a lot. Along the lines of morbidity and mortality conferences, we also use these a lot in teaching, so that we know that case-based learning is one of the most popular and effective teaching modalities in medical education. So most cases, most teaching opportunities are based in cases. Finally, we often use it more than I think we realize in real-time clinical practice when we are faced with what we call a stalled workup, which is basically you've been working up a patient, you thought they had a diagnosis, and things aren't going the way you expected. Either they're not getting better, they're getting worse, or there's some new piece of information that makes you rethink them. We often at that point have to step back and look through the case to figure out what's going on. So it turns out that preparing a true case review is actually quite challenging. By the nature of case review, you are brought a case that had a diagnosis or an outcome that was undesirable, and so as the preparer, you automatically have what we call hindsight bias. Basically, every piece of information that you look at as you prepare the case comes with your knowledge of what the final outcome was. In that same vein, because you're starting with all the information as opposed to getting it over time, a lot of case reviews end up presenting the information without attention paying to the chronicity of the case or how the information rolled out. Both of these together come down to the problem of misrepresenting the authentic clinical situation as it happened in real time. And if we can't reproduce that authentic clinical situation, then we can't really get at what is the real problem or what is the real learning point of that case. So to understand this even further, I think we really need to spend some time understanding how dynamic illness scripts are. We often talk about a case who say, oh, this guy came in with these symptoms for this many days, he had this x-ray, and the diagnosis was this. It was an amazing case. But that's actually not how it happens in real life, right? Most cases are presented as a string of what I call information bundles that are separated in time and space. So you can imagine that triage is one bundle. They come in with some complaint. Maybe they get some vital signs. Then they go and you do your history taking on the patient. That's another bundle of information. You do an exam, another bundle. Maybe you get some labs or some imaging done, another bundle. Response to time, response to treatment, so on. These are all information bundles that are separated sometimes days, even weeks over time. And so that's how a case really happens. Now, each of these information bundles is a time where you have to update your patient illness script. And so the illness script is constantly changing. And each of these updates presents as a fork in the road, in a way, if you want to think about it. And each of these forks in the road, of course, is an opportunity for us to have a better understanding or improved understanding of our patient. But they also represent the opportunity to be misled or misdirected if you didn't use the information correctly or you didn't have the right information or whatever it may be. So to appreciate this a little bit further, how dynamic these patient illness scripts are, let's just go through two cases. So the first case I would consider kind of a linear or straightforward case. So let's imagine a child's brought in by his parents complaining of arm pain after falling while he was ice skating. You do a physical exam, and he appears in pain, and there's clear bony deformity of his left arm. So you order an x-ray, and the x-ray, as you expected, shows a displaced fracture of the left ulna and radius, and you make your diagnosis of a displaced fracture of the left wrist. Now let's look at what actually happened to that patient's illness script during this case, okay? So we came in to triage, and you get your first illness script, and it says that this is a young child. You can put in your epidemiology that he's an ice skater, I guess. His duration is acute onset of forearm pain after falling. You do your exam, and so that updates your illness script that you found this bony deformity on exam, and of course then you get your next piece of information from the x-ray, and that shows that there's an x-ray on, there's a fracture on x-ray, and so you make your diagnosis, okay? A lot of people would consider this straightforward, and we wouldn't usually spend much time thinking through the case, through one of these cases, right? But let's see why it was so simple. So first of all, there was good information in the initial bundle that you got in triage. So this kid had fallen on his arm and he had pain in that arm. That allowed for really quick pattern recognition of what's probably going on. All the subsequent information that you got fit the initial working diagnosis. You were worried about a fracture all along, and the exam and the imaging all fit with that as you went along. And then there was no discordant or distracting information, so there was nothing that made you have to step back and think, well, what else could be going on? There was nothing that challenged the route that you were already taking with the patient. Imagine if he suddenly spiked a fever or became tachycardic or had shortness of breath all of a sudden, you would be in a very different place than just diagnosing a fracture. So along those lines, let's consider a more complex case. This second case is a patient, let's say she's a 65-year-old woman who presents to the ED feeling terrible. So you take your history, and she complains of shortness of breath, productive cough, and fevers for the last 3 days. You do your exam, and you pick up rhonchi at the left base. You order some labs and imaging, and you get a leukocytosis and a chest x-ray with a clear consolidation in the left lower lobe, so you make your diagnosis of community-acquired pneumonia. In this case, I'll represent that as CAP, okay? This wouldn't be so different for the average internist out there. This wouldn't be so different than diagnosing a broken arm in a kid. It's fairly linear and fairly straightforward. But now let's imagine that a few days into therapy for the community-acquired pneumonia, the fevers and leukocytosis have improved, but the patient's still complaining of dyspnea and dry cough. So what do? Well, you go back and you take more history from the patient. You say, and the patient now says, well, you know, actually I've been having worsening shortness of breath and dry cough actually over the last 2 months probably. So that makes you wonder, so you do another exam of the patient, maybe listening more closely. And you hear that the rhonchi have resolved, but now you pick up crackles throughout the lungs bilaterally. So you go back to the patient now, and you say, so what else has been going on? And you learn, well, in fact, the patient just bought a parakeet not too long ago and has a parakeet in their house. Well, this makes you concerned, so you order a CT, a CAT scan of their chest, and it's consistent with hypersensitivity pneumonitis, and you make your diagnosis. Okay? So let's look at what happened to the illness script in this case and appreciate how much more that illness script changed from when the patient presented in the emergency room to when you made your final diagnosis at the end. So on triage and after your exam, or after your history, you get that this is a 66-year-old woman. As far as you know, she was previously healthy. Comes in with acute or subacute productive cough, shortness of breath, and fevers. You did your exam, and that showed rhonchi in the left lower lobe. You ordered a chest x-ray, and that showed left lower lobe on the chest x-ray, and you made your diagnosis off of that, okay? This actually doesn't look, again, too different from what happened with the broken wrist. But then things changed. Time passes, you get new history, and the first thing you have to do is you realize that your duration was actually wrong, that there was actually something chronic going on with this patient, so you have to change that. Well, if there's something chronic going on, you have to change your epidemiology, and it's question whether this patient really was previously healthy, so you got to take that away. Now you start looking through your symptoms that the patient had, and productive cough, shortness of breath, fevers. It sounded a lot like community-acquired pneumonia. How are you going to represent that on the illness script in the face of this new information? Well, you're going to take all that information and maybe you just wrap it up into one bundle and call it the patient recently had community-acquired pneumonia. And you factor that in with your old, the symptoms that you're now getting, so the dry cough and the dyspnea on exertion. You do your history again, your physical exam again, and you get diffuse crackles. You learn that she owns a bird now, and you do your CT scan that it's consistent with interstitial lung disease or hypersensitivity pneumonitis, and you make your diagnosis of hypersensitivity pneumonitis. Look how different this illness script looked from when you started. So what made this case so complicated? First of all, you really get a sense of information coming in multiple bundles separated over time. In fact, this might have happened over a week or so. The symptoms and complaints weren't totally straightforward. In fact, they were layered. There were some acute symptoms and some chronic symptoms. And for instance, on the lung exam, there were layered symptoms in a way. You had the rhonchi, and maybe the crackles were there, maybe they weren't. But there were multiple layers to this information. Finally, the initial diagnosis, community-acquired pneumonia, started to get challenged halfway through the case as the patient didn't seem to get better. The shortness of breath didn't get better. The cough changed, and so you had to rethink the case. Well, you could say, well, great, I came to the final diagnosis anyway. But let's imagine that somebody looks over the case and it turns out, I don't know, the patient got a C. difficile colitis or a drug rash and says, why in the world did you ever treat her with antibiotics for community-acquired pneumonia when we know that she had hypersensitivity pneumonitis? Why would you do that? Or let's say someone takes interest in the case and says, well, do you really think this was community-acquired pneumonia and hypersensitivity pneumonitis? Or do you think this was just hypersensitivity pneumonitis all along? Again, you'd have to think through your case. Finally, let's say that, I don't know, a radiologist is looking over the x-ray and comes to you and says, this is classic hypersensitivity pneumonitis on the initial chest x-ray. How did you miss it? Well, all of these questions are the types of things that's going to make you have to look back through your case. And imagine trying to structure your thinking and explain your answers to all these questions just by without some kind of structure to it. Okay? So I think this is where problem mapping can come in, all right? So what is problem mapping? Well, it's a visual representation of a complex case, and I think what it really brings is added attention to the extra dimension of chronology to a case. What it does is puts focus on what I call clinical moments, okay? And a clinical moment is the data available at some point in time. It might be your information bundles, okay? It has your patient illness script as updated at that clinical moment in time. And then your working diagnosis. What did you think was going on with the patient at that moment in time? Those three things together makes a clinical moment. It's these clinical moments and identifying them that become our points for intervention and improvement in our case review for whatever reason we're doing case review. Okay, so let's show you what a problem map could look like. And we'll start with case 1 because I think it's a little bit more straightforward, and then we'll show you case 2. So imagine you're at a whiteboard in front of a group. That's how we do a lot of our kind of case conferences here at UCSF. It may be different at your institution, but let's imagine we're at a whiteboard. And over on the right side of the whiteboard, we're going to keep track of our patient illness script and how it's updated over time. Okay, and then we're going to use the left side of the board to draw our problem map. Okay. So you're going to start with your first information bundle. The patient fell and had acute arm pain in this case. And you update your patient illness script. That shows that this is a young, healthy kid who was ice skating, acute onset of left forearm pain after falling. Okay? And then you update your differential diagnosis or your working diagnosis to say that you were pretty worried at that point in time about having a fracture. You put these three things together, and that is your first clinical moment. That's clinical moment number 1, okay? Now, let's do the next step. So you did your exam, and there was a deformed arm on exam. You update your patient illness script. You draw a line to your next differential diagnosis or your working diagnosis at that point in time. It's still a fracture, of course. And this now is your second clinical moment, okay? So we continue through. Our next information bundle, our third information bundle, was the X-ray that showed a fracture. You update your patient illness script. You update your final diagnosis, which is a fracture, okay? This is what, in a very simple way, a problem map would look like, okay? Now let's do case 2, okay? And this isn't going to be quite as linear, all right? So we start with our patient illness script section over on the right side of the board. Our first information bundle is that the patient comes in with cough, fevers, and shortness of breath. We update our patient illness script that shows that this is a 66-year-old woman. We think she's healthy. The duration seems acute or subacute, productive cough, fevers, and shortness of breath. And you update your working diagnosis. There may be other working diagnoses based on this, but in this case, let's say you were worried about community-acquired pneumonia. This, of course, just to kind of hammer home this point, this would be your first clinical moment, these three components, all right? So we move on to our next clinical moment, which is that you do an exam, and that shows left lower lobe rhonchi. You update your patient illness script to show that, and you update your working diagnosis, which is community-acquired pneumonia. It hasn't changed yet. All right, so we push through information bundle number 3. You get a chest x-ray that shows a consolidation. You update your patient illness script, and then you update your working diagnosis at that point in time, which you thought was your final diagnosis, which is community-acquired pneumonia, okay? Fourth information bundle is that patient's not getting better. It comes up that she's had 2 months of dry cough, dyspnea on exertion, and crackles. You update your patient illness scripts, and now you've changed your duration. You've taken away that you think she's healthy at baseline, and you've narrowed all of those initial symptoms down to being recent acute community-acquired pneumonia and your new symptoms. And you update your differential diagnosis, which is, at this point, you're just wondering, is this really community-acquired pneumonia? You actually don't know what else is going on. So you go back and you talk to the patient, and the patient says, well, you know, I actually own a bird. You update your illness script. You update your working diagnosis to be ILD or hypersensitivity pneumonitis. Your next information bundle, you get the CT scan. You update your illness script that shows that she has ILD or hypersensitivity pneumonitis. You update to have your final diagnosis, which is that this patient also had hypersensitivity pneumonitis. Take a look at how much more complex that is, and see how nice it is to have everything laid out, okay? So now let's say we're doing a case review. Now we can go back and say, well, you know, let's look at information, clinical moment number 1. Did we actually have the correct duration? Was it a problem that we didn't take enough history with the patient? We stopped as soon as we learned that there was 3 days of symptoms? Or did the patient withhold that information from us? Or did we just not spend enough time trying to figure out what our duration was? Then we move on to clinical moment number 2, and you ask, you know, were there actually crackles on exam all along? There probably were. So were the rhonchi covering them up? Was I not listening carefully enough? Or for some reason, did they not show up till later on? So you can analyze clinical moment number 2. And just to make the point, then you come to clinical moment number 3, which is the chest x-ray with consolidation. And you might say, well, did I actually read it with a radiologist? A lot of internists read their own chest x-rays. I certainly do. And so maybe actually we missed that read with the radiologist. Or maybe the radiologist missed it, or whatever it is. Anyway, that gives you this third clinical moment that you can analyze. And you could do that for every one of these clinical moments to identify points of improvement, and to identify teaching moments along the way. So that's a problem map, and really this is a flexible idea that we're really kind of working on right now in terms of how you can use it, and you can adjust it and change it to fit your situation or the problem you're trying to tackle. So a couple different ways that problem mapping or problem mapping like things could be used. So certainly in QI or improvement type work, you do a root cause analysis. So this could just be a way that you structure your a structure for organizing the data that you have. Remember, I said one of the challenges of putting together a case conference is that you have all this data up front and you need to put it in its right place. This reminds you to be diligent about where really was that exam. When did they get those labs? When did the patient tell them they just bought a parakeet? Whatever it might be. It also, as I was just saying, can help you identify points for possible cause of a bad outcome or a place to improve in the future. But you can also use it in other places. So imagine you're preparing a teaching case, either a morbidity mortality conference or an interesting case you want the residents or medical students to learn from. This can be your outline for the case review and can help you, instead of identifying places where you could have done things better, could help you identify, well, I want to make sure at clinical moment 3 that we really spend some time around the thinking at that point in time with that information and that understanding of the patient. You may use it in real time for case conference. So I don't know how you guys do case conference at your institution, but here we kind of just scribble the information up on the board with the physical exam and the labs and everything. You could imagine actually building, instead of doing that, building a problem map as you go through the case. So that'd be another way it could be used. And finally, it's a really nice way to summarize a case afterwards. So a lot of our morbidity and mortality conferences have a QI component or a systems component we want to emphasize. And laying this out afterwards could be a nice way to review the case and also, again, to identify places where we could do things better. Finally, in real-time clinical use, like I was saying at the beginning, we can use this model for stalled workup. So going back in time and saying, what was my understanding of the patient when I saw them in the emergency room? What information did I have available to me at that time? And what was I thinking about them? And could I have done it differently? And then one other thing that I'm starting to play with, I haven't put it into full use yet because I haven't quite figured out how to make it happen, but this could be a way of updating your daily progress notes for communicating your thinking to other providers, which is the point of the medical record in a lot of ways. For those of you who aren't in medicine, our notes generally end with an assessment and plan. The assessment is what we think is going on with the patient. The plan is, what we're going to do with the patient. And this could be a way that you structure your assessment. So you could say, this is the information I have for me right now. This is my patient illness script as the way I understand the patient. And this is my working diagnosis. This is my clinical moment, which will help you going forward in terms of better communication and better understanding of how you're thinking about the patient. It would also help you if you have to go back and think, what was I thinking about at that time? There it would be in the medical record. So in summary, case review, plays a really important part in a lot of ways in error analysis, in education, and quality improvement in medicine. Having a structured approach to case review may help you avoid some of the common biases of putting together a case review and actually strengthen that review. Finally, we introduce problem mapping, which is just a way to accurately characterize a case's clinical moments, giving chronology to a case and really understanding the importance of chronology in clinical problem solving. And it can help you identify points of action, whether that be quality improvement or patient care or education. So that brings us to our question 5.5. The question is, problem mapping, 1, shows students which problems to study. 2 is a visual demonstration of the impact of information on decision making, or 3 is typically used prospectively. The correct answer, of course, is that this is problem mapping is a visual demonstration of the impact of information on clinical decision making. The key issues from Module 5, as we just to wrap up. So diagnostic error is very common and can occur during any step in the diagnosis and treatment process. Knowledge gaps tend to cause or where errors can occur when people are unaware of how diseases usually present. Knowledgeable physicians can still make errors because of their cognitive biases, and we covered a number of those biases and how they could mislead even the best physicians. And finally, we introduced you to a model for approaching case review and even using it in real-time clinical practice, which we call problem mapping, which can help uncover hidden biases and other cognitive errors. Okay, so that's the end of Module 5, and I hope that was informational. I hope there's things that you can take back to your practice, and we look forward to seeing you next week in Module 6.